community pharmacy. Some of the BBV prevention and testing we were able to do, we actually, again, I think we're able to have contact with people in a way in which we hadn't managed pre-COVID, which has been a really kind of interesting reflection from us. We had already started the work with the prison populator, people just discharged from prison, in terms of OST and the day they left, but we were able to prioritise that across the city in a way in which we hadn't pre-COVID, and that we also had the, I can't say this, buprenorphine pilot, which again, real success for us. And I think what we've experienced as the stabilisation that brought to that client group, and then allowed us to offer the BBV testing to folks at risk, which was, again, a really innovative way of working with people. Our colleagues in public health and others might say more about this, actually showed an increase in terms of our HIV testing since 2019. But actually, again, our experience during COVID has been because we were able to maintain contact with that complex group of people in the hotels in particular. We were able to continue to increase access to all of the BBV testing, including HIV. So whilst we had some real challenges initially in responding to COVID-19 in terms of this population involved in public drug injecting, and this population who are therefore highly vulnerable in terms of HIV, and whom we struggled getting into treatment and care services, actually, as we've continued to work with the population, if anything, what I think we've seen and the feedback that we're getting is we've stabilised that contact and intervention, but now found new ways of maintaining contact with people, which has allowed us to improve that connection to folk. Nathan, I don't have my slides in front of me. I think that maybe, there we are. Sorry, the rest of those slides talk about, that was the IEP provision that I talked about, and there's the van. That's the first van, we've now got two. If we move on, and that just shows you what our IEP has been able to do throughout from 2015 onwards. Moving on. Again, some of that, the increase in testing in the alcohol and drug service continues to be a challenge for us in the mainstream alcohol and drug services. And we had to do some more work with that, our staff in relation to their training and offering that as routine testing. But we've seen some of that improve significantly with that hotel population more recently. Moving on. So I think the summary from us would be that we have been working really hard to meet the recommendations from the Taking Away the Chaos report. We continue to argue that the lack of a safe drug consumption facility in Glasgow remains quite a significant gap for us in terms of having all of the tools at our disposal to make sure that we could hand on heart say we're doing all that we can in terms of addressing those issues. We're really clear as an alcohol and drugs partnership, health and social care partnership, that we will continue to lobby for a safe drug consumption facility in Glasgow. As optimists, we've continued to work in the background, and we now have a suite of standard operating procedures when we get the go-ahead in terms of a safe drug consumption facility in the city. We've made a clear commitment financially, and we will retain that financial commitment to fund a safe drug consumption facility in the city. And as I say, we are working on how exactly that might operate, learning all the time about how it might best operate, but continue to see it as a gap in terms of how we will properly respond to the HIV outbreak that we are experiencing. That probably is the last slide. Sorry, Nathan. Yeah, that's the last slide.
Thank you very much, Suzanne. And we'll have time for questions in the next half an hour. I know there's already been one come through the Q&A for you, but we'll move next to Dr. Erica Peters from NHS Greater Glasgow and Clyde. And again, Erica, if you just want to let me know when the next slide is, I'll do that.
Yeah, that's great. Thank you, Nathan. Just my first slide, please. So I'm an infectious diseases consultant physician based at the Queen Elizabeth University Hospital. This is a picture of the hospital where I'm sitting in just now. So it's a very modern hospital, opened in 2015. It's one of the biggest hospitals in Europe. What we're trying to do is provide a service that can span the whole population in Glasgow. So traditionally our HIV service was based in a hospital setting, a single service, which was built for first, the intentions were that we'd have everything on one site, a one-stop shop, if you like. When we recognised an outbreak of HIV, we realised that that was not reaching our vulnerable population, namely the homeless city centre population that have already been described. Next slide, please, Nathan. So in 9 minutes, you've asked me to describe the role of the NHS to this outbreak, which is impossible, because NHS, in most of you I think are from Scotland, but a lot of you from overseas, is multifactorial. And the idea is that we move across all facets of our population through all ages and all backgrounds, and try and provide a high quality healthcare service. So we're trying to provide a service for people that might be homeless, to people that are maybe elderly from more privileged backgrounds. I think if we go through this wheel, I'm afraid I don't have an arrow, but at the top you see secondary care. So this is traditionally where our hospital-based care is. Primary care, GP and primary care services where patients would normally be referred into us. And this is how HIV traditionally works. But if I think about an HIV patient in this injecting population that we're dealing with, they go through a whole lot of different aspects of the NHS. So we have ancillary care staff, we have band 3 healthcare assistants working with us, we have qualified nurses, we have doctors, pharmacists. Pharmacists are important in what I do because we have links between community and our HIV specialist hospital pharmacy services. The public health is within the NHS, and that's really driven our response to this outbreak. We have administrative staff. We've already heard from health and social care partnerships. We have patients accessing our acute unscheduled care very, very regularly, and we need to work with them. I'm an infectious diseases physician. My other colleague that works with me on this outbreak is genitourinary medicine. So we're able to provide a comprehensive sexual health response, as well as responding to other infections. I think Andy already alluded to the number of different infections that this population can suffer from out with bloodborne viruses. The patients are in and out of emergency departments. They're high users of radiology, laboratory services, counselling services that all sit within the NHS. The alcohol and drug recovery services that Suzanne's mentioned. Clearly significant mental health problems here, so we're often finding patients within community psychiatry, but also in acute psychiatry settings as well. And we've had to work at a board level and within our national structures. We already had an established prison healthcare model for bloodborne viruses. We have 3 prisons in our health board area. And so we were already providing HIV and hepatitis C care within the prison sector led by secondary care. So it's very comprehensive, and I can't cover it all just now. Next slide, I think there's a little star, Nathan, if you can press that. So as part of the public health response, I've been involved in the clinical response to the treatment as prevention. Next star, Nathan. So I'm just going to briefly describe what we have done for the clinical response to this outbreak. Next slide, please. So you've already seen this graphic. It's broken down per quarter in terms of the outbreak based on from when it was first originally recognised at the beginning of 2015. And at that stage, we had an immediate management team, the normal response to a public health outbreak set up. And there was a broad response organised through the public health leadership there. What we did clinically was recognise that these patients were not going to be able to travel to our clinic, which is about 4 miles outside of the city centre in one of our hospitals, more remote from the city centre. And we had to bring our service to them. And I think the important thing you learn from health inequality work is the aim is to provide a quality service, but your route there may be very different to another group of patients. The really important thing I think we did at the beginning was have our nurse work very closely with all these different partners involved, including non-NHS partners, and really work with the patients directly, including working actually literally on the street with them, as well as working in the hostels and with the pharmacists, the pharmacists that they went in the community. And we were able to link HIV care into their opiate prescription as well, so that when a patient went, for example, for their methadone prescription, every day. They could also get their HIV supervised as well. And these small practical things are so important for people that are homeless, maybe moving around the city a lot, have nowhere to store their medication, even if otherwise they would be willing to take it. And we've essentially, as our numbers have increased, we've had to escalate the clinical input into that. So there's been quite a lot of advocacy work to try and do that. And we managed to set up a consultant-led clinic within a homeless healthcare setting that's in the city centres. It's geographically very close to these patients generally, and all the patients were more or less familiar with that setting. Originally it was an HIV clinic, but we expanded that to be a bloodborne virus clinic. Most of these patients are co-infected with hepatitis C and required that treated. And it also slightly reduced the stigma associated with HIV on its own. And we've managed to expand that numbers-wise so that we now have quite a comprehensive team, and we're able to support the patients well through all the different facets of their healthcare journey, if you like. And we've called that Glasgow Enhanced Care HIV Outbreak model. Next slide, please. So we have to prove that this model works, because unfortunately in healthcare today, you know, we are, as important as a national health, a public body, that we justify what we do and justify the expense of paying consultants and nurses to do this sort of work. And we've published this recently in the Journal of Infectious Diseases if you want to read more details on that. But what we can do is measure how long it takes a patient to start antivirals and how good the response is to that. So in the first graph you can see here, this is the days from diagnosis to initiation of antiretroviral therapy. And through various changes that I don't have time to go into today, we've managed to reduce the time to starting treatment down to basically we try and do it on the same day that they get their diagnosis, which most of the time is possible, but you can imagine there are some challenges with that. But that's very important, because obviously the quicker we can get them undetectable from a public health response, we're less likely to have onward transmission. And also from a patient's individual perspective, it's clearly important for their long-term mortality and morbidity going forward that they get started onto treatment as soon as possible. But I think it's also, particularly for this patient group, very important for their self-esteem to know that people are listening to them and are concerned with them and are supporting them in this journey. The other graph shows that we can achieve a high quality response despite all the challenges that are faced with this group, extremely vulnerable problems that have been alluded to already. Currently this year, we're up to 90% of our patients are undetectable on treatment. So at present we have, I think that's actually gone up to 187, but we have 187 patients have been diagnosed as part of this outbreak, and we have a high mortality rate, but that mortality is not related to HIV. Next slide, please. So this is my last slide, and essentially, it's a very complex picture. The patients are extremely complex, and they're probably the most vulnerable population in our health board area, I would suggest. We work closely with other partners, and you're going to hear from one of them soon. But I think it's really important that the quality of care that we can offer these patients shouldn't be any different to any of the other groups that we work with in my line of work as well. And I think we've been able to show that we can get good quality care for these patients by having a comprehensive service for them. And the only way that we can do this, from my perspective, is think about these patients from their point of view as individuals, and thinking about all the care needs that they have. It's not just about their HIV, it's not just about their housing, it's not about their addiction issues, it's thinking about them as individuals, as well as thinking about the group size of this. That's my timer reminding me that my 9 minutes is up. So I'm just going to stop there. This picture on here is a painting by one of our local artists, Ian Campbell. It's called Our Last Supper. And I think it's just to recognise that all these individuals have great stories. They're really enlightening to work with. And I've just really enjoyed this journey, even though it has been extremely challenging. Thanks.
Thank you, Erica. I'm now going to hand over to Mary McKean from Waverley Care, who's going to pop on the video and unmute herself just now to have that next presentation. And then after Mary, we are going to have our question and answers. So there's already some questions in the box, and Andrew's been answering them as well. So we'll have the chance to have a group conversation. But Mary, over to you.
Okay, I seem to have lost the video, Nathan.
You should be able to just click start video now. It should work.
Start video now.
There we go.
Okay, thank you, thank you. Not very technically minded, I'm afraid. Hiya, yeah, next slide please, Nathan. And next slide again, hiya. And next slide, yeah, that's me, sorry. Hi, I'm Mary and I work with the HIV street support team at Waverley Care, based in Glasgow, mainly city centre. A lot of the people you've heard, Fiona, Andrew, Suzanne and Erica, a lot of things, you know, I echo that as well, and particularly what Erica was saying before about, you know, this being about individuals. You know, obviously there's an outbreak from a public health perspective, but it's about individual lives and individual people we're talking about here. And I think that's just really, really important. We've tried to create a service that is accessible. So we, from day one, the project was set up in November 2018 when Waverley Care secured funding, trying to make it accessible. So we're very keen to do assertive outreach. We went out into the streets of Glasgow to meet where people were, rather than expecting people to come to us. Again, very importantly, was holistic and person-centred. It was very much, you know, led by the people we worked with, and very much looking at, you know, a whole range of issues. You know, HIV does not occur in isolation. There's a lot of contributing factors, and also, you know, people will have complex lives and complex issues. So making sure we're coming at from that perspective. In partnership, you know, just hearing Suzanne and Erica there, the reality is a lot of this work would not happen unless we're working in partnership, and that's been a really key thing within Glasgow, is the way in which organisations are working collaboratively to try and, you know, meet the needs of the people we're working with. Again, targeted in terms of, you know, making sure that, you know, we are reaching the people, you know, that need the support that's been offered. And a key thing has been informed by lived experience, that ensuring that the voices of people who we work with are actually, you know, feeding into that process and actively involved in decision making, actively involved in the direction in which the work goes in. Next slide, please, Nathan. Okay. Our team will get various approaches. So support, we do have a combination of, we do face-to-face work with people who are living with HIV and some people at heightened risk of HIV. We do a lot of street work where we actually go out in the streets of Glasgow to look at supporting people, or even just building relationships with people who are at heightened risk or living with HIV. That also involves HIV testing, where we use point of care testing, which is we use the BioSure. So it's really easy. What we're trying to do is increase accessibility to testing, but also in a discreet way, so it doesn't take a long time, you know. And also we're very clear to ask people, because obviously a lot of people are out working, earning money, you know, for a whole variety of reasons. So, you know, we don't want you just, there sometimes can be a lot of workers out there, and you're also being very mindful that people are out there trying to make their money and have got their lives to lead. So you want to do it in a way that's accessible and appropriate for the people we're working with. We're doing a lot on IEP. Suzanne was talking before about during COVID, we've been very actively involved in that during the national lockdown with the IEP manager and various organisations, and being involved in the needle exchange van and going out the streets of Glasgow, ensuring people had clean injecting equipment, but also with like overdose, giving out naloxone, but also overdose reversal. And, you know, kind of obviously people have spoken about this before, you know, a lot of people dying with other related, you know, people are dying through drug deaths, people are dying through underlying health conditions, a whole range of issues that are not directly connected to HIV, but their root causes are connected to HIV. Another harm reduction work, you know, around sexual health, around providing sexual health advice, sanitary products, condoms, also referring on to the sexual health team, who do amazing work within Glasgow City Centre as well. We also do dry blood spot testing as well if it's appropriate. As I think we said before, I think it was Andrew was saying, and possibly Erica as well, a lot of people we work with are also living with Hep C sometimes for many, many years, which is a wider harm with injecting drug use. So again, about trying to make services as accessible as possible. A lot of services are designed in a way that people have to come into services, and the reality is it's about being needs-led and, you know, creating services that meet the needs of the people we're working with. Next slide, please. Okay, I think, you know, when we're out doing street work, crisis management's a big factor. You know, we'll often respond to, as I said before, overdose prevention, first aid, or just help people who are heavily under the influence to get up the road or get access to medical treatment. You know, and you go out in street work with an intention of how it's going to work, but you just have to be led by what the needs are when you're out. Sometimes it's literally just having a chat with someone, you know, seeing if someone wants a hot drink, something to eat, you know, just about building those relationships. And also for us, it's very much about many people we work with, their lives dominated by workers. And first and foremost, we want to create that relationship as in two human beings. We meet some of the most resilient people every single day, and I think for us it's really important to remember that we're a drop in the ocean, and it's always been led by people themselves. We also have a women's worker, because obviously we know that women were disproportionately affected in the outbreak compared to other outbreaks, but also looking at reducing engaging barriers, reducing barriers to enabling people to engage in services, but also in a way of improving overall health and wellbeing. Disengagement is a key issue, as I'm sure you are aware, and I know that particularly Erica's team have worked really hard to get people onto ARVs, and it's, obviously it's excellent work that's being done. I think one of the big issues for us is we are working with a lot of people who are engaging in treatment, and they're possibly getting that with their ORT on daily dispense. But one of the big issues for us is people are on ARVs, people are on ORT, but they're still begging, they're still homeless, they're still living in poverty. All those wider harms, all those wider issues are still there. And a lot of people we work with, there's a lot of self-stigma, as well as the stigma they face on so many different levels, whether it's because they're living in poverty or homeless and injecting drug use, or so many layers of stigma that are already there, and HIV is yet another layer of stigma. And there's a lot of self-stigma where people are talking about, well, I injected that needle myself, so therefore it's my fault. So it's the whole thing about self-worth, self-esteem, and working with people around that. Next slide, please, Nathan. Okay, as I said before, we work in collaboration with a lot of different partners, which I think is key. Suzanne has spoken about the city centre harm reduction. She was talking about the city centre engagement group before. And that's something that I can't really go into just now, but it's been an amazing piece of work that was initiated by SDF. And it's about enabling people to have a voice. So it's not service-led, it's about people themselves, people who are still continuing to use drugs. So thinking back to what Fiona said, we have this kind of two-tier system of what's acceptable and what's not, what's legal and what's not. And a lot of services are available to people who are in recovery or who are abstinent, and we're trying to create a forum where, there's no judgment involved. People can still have a voice. People should still have a voice when they're using drugs. Again, the harms group, talking before about the BBD team, the Phoenix team, who are the outreach pharmacy team, who've done a lot of work with, who've been amazing, getting medication to people within half an hour who are homeless and kind of doing the emergency treatment. But as I say, there's kind of a lot of areas here. And IEP manager John Campbell, he always has to get mentioned because he's great. The next slide, please. Okay, I think what I'd spoken before, and I think we are really, really keen to kind of raise all the underlying issues. There's very strong links between poverty and the heightened risk of HIV. People who inject drugs are up to 20 times more likely to be at risk of contracting HIV. There's a lot of stuff's coming out through the WAND initiative that we've been involved in terms of changing the injecting practice. So although there's really comprehensive needle exchange within Glasgow City, there's still a lot of concern about injecting practice at the moment. Mental health and trauma, I think that goes without saying, background trauma, mental health, but also poverty has big impacts on mental health, and there can be traumatic events for that as well. Homelessness, as Suzanne was talking about before, with the hotels we bring, people going into hotels, and that has enabled increased engagement. But unfortunately, it's been quite negative experiences for some of the people we're working with. Criminal justice, going back to what Fiona was saying, the constant criminalisation of people who use drugs, and also then forcing people into public injecting down alleyways and where it's really unsafe, isolation, bereavement, all the things we've kind of spoken about before. Next slide, please. My way to go. Next slide again, sorry. Our brilliant comms workers put in all great photographs. Just in terms of the 90-90-90 targets, obviously in the commitment from Fast Track Cities, I want to kind of focus on the kind of last one, improve the health, quality of life and wellbeing of people with HIV across Glasgow. I think that's what we are seeing, that people are adhering to treatment, which is fantastic. but sometimes it's, you know, it's because it's daily dispenses, that people have an investment in their own health and believing that they deserve to have that treatment, believing that, you know, they've got right to quality life, they've got right to have a voice. So I think it's about looking at about those, you know, those underlying issues. Move on to the next slide, please. Sorry, that's better. Yeah, I think again, I know Eric had touched on this as well, and Fiona, about social economic factors. The big thing you're seeing is because of criminalisation of drug use, you've got people who are having like a quarter of their benefit arrested from the courts. So you're talking about somebody on £400, £300 to live on for that month. You know, just in terms of, you know, the welfare system, the wider, you know, as Andrew spoke about before, the outbreaks expanded to other area. Suzanne said about housing, you know, homelessness, street begging, street homeless as well. Criminal justice system, very punitive system in terms of, and again, quite a divided, people are treated very differently depending on what drugs they use. COVID-19, also that did bring its challenges. I think it was Suzanne said about isolation. You know, a lot of issues around isolation, but just the fact that, you know, people aren't able to use services in the same way anymore. And when what's really interesting from us well, me as an individual, is like homelessness has been a massive issue in Glasgow, people sleeping in the streets in freezing cold weather. But as soon as the wider community was affected, they could all be accommodated. It's not the best accommodation, but suddenly they were all indoors. And I think just, you know, funding wider issues. I think, you know, for us, it's about, it is the wider, how we influence wider social policy, how we influence wider issues like looking at root causes of poverty, trauma, criminalisation of people who use drugs. So there's, as Erica said, there's a lot more to do, but I think, you know, it's about investing in individuals, you know, and seeing people, as we all like to be seen, rather than, you know, drug use or criminalisation or poverty. It's about looking at the standpoint of like, let's look at the structural factors that cause this and build on that. I think that's my last slide. Yeah, thank you.
Perfect. Thanks, Mary, for that. And I think we're going to welcome other participants back, although I think we're going to have another problem with our cameras. For some reason, Zoom doesn't want to see all of our pretty faces. But I just wanted to run through some of the Q&A, because a couple of the panelists have been furiously answering questions so I want to make sure that people that are watching back also can see these questions. So we've got Ronnie Cowan asked, why are people injecting cocaine more likely to contract HIV? And Andrew has answered that. One, cocaine is a stimulant, so people are more likely to inject more frequently and more riskily, more likely to reuse and share equipment. Cocaine increases your libido, so people who inject drugs are also at risk of contracting HIV from sexual transmission. And people who inject cocaine have poorer drug treatment engagements and outcomes, including for OST, which is one of the main HIV prevention interventions. I'll make sure that the link that Andrew has submitted there is also gets circulated. What's caused the spike in infection? Have the issues been addressed? Erica's said that in 2015 there's been a big push in testing, so the figures increased sharply after a variety of initiatives and publicity were increased. We had another question: did the strain, the current outbreak, link back to originate in Glasgow? And Andrew's come in there with some information about the virology lab in GGC sequencing all HIV infections, and another academic study there that we'll make sure is circulated. Julie's asked what ways peers connect with the peers connecting throughout COVID, and what kind of things have been done from the Health and Social Care Partnership. And Suzanne has said that it was the recovery movement which has led this, establishing themselves virtually, using technology to connect, to continue to hold events and offer one-on-one support. Peter, who I had the delight to sit down in conversation with earlier, and you can watch that on replay at the conference site, asked, what can the Health and Social Care Partnership and partners do to tackle the increase in cocaine injecting? And Suzanne said that this sits in our wider harm reduction work for the Health and Social Care Partnership understanding factors leading to increase ensuring access to treatment and care. And we've had one final question. So this is, we've only got 4 minutes left of this session. So I'm going to pose this to our speakers, and whoever wants to come off mute and answer this is more than happy to do so. In the pilot Glasgow drug consumption room, a lot of people are reporting a lack of support when trying to engage with services. Is this mostly down to COVID restrictions, or is it linked back to budget cuts for alcohol and drug partnerships in 2016? So I'll potentially go to Mary, and then Suzanne's come off mute as well. So Suzanne and Mary, if you want to answer this one.
Yeah, I personally think it's both. I think during COVID, it was, you know, a lot of services for lots of reasons did become inaccessible, and I think that was a problem, and hence why the kind of crisis response was kind of put in place. Because the reality is, you know, in order to support the people we work with, you have to, well, we feel you have to be out there. There's no other way, and I understand that there's a lot of challenges. And I think as well, there's different organisations depending who, you know, whether you're a statutory organisation or voluntary organisation. As a voluntary organisation, we worked through a lot of different policies to enable us to go, you know, looked really hard to see how we could get back out there. I know it's not quite the same for the statutory bodies. We maybe had a wee bit more freedom, but I think definitely both.
And Suzanne and Erica, as I see you're unmuted as well. So I'll go to Suzanne first and then Erica after Suzanne.
I think certainly in terms of, there were absolutely initial challenges, as Mary said, in relation to the mainstream statutory services during COVID. But actually, they were then reconfigured to outreach services and to be able to work with people directly where they were. And during up to, I think this is, I can confirm this, Nathan, but I'm pretty sure it was up till the end of October. From the end of March, we had 130 new clients registered and receiving treatment, ORT treatment, over the course. So we weren't closed, kind of contrary to a perceived view, but as Mary said, pathways in were very different. So it may well have been difficult for people to negotiate. But in actual fact, we continue to see and continue to accept new clients, new patients. The issue about ADP funding for us in the city, and I know it's different elsewhere in Scotland. So the ADP funding, while extremely welcome, is a really small element of the funding for alcohol and drug services in the city. So our ADP funding fluctuates because you quite often get one-off spends in there, but it's roughly about 45 million. But our spend in mainstream alcohol and drug services and health and social care partnerships, 41 million. So the kind of pressure on the public pound that does have an impact across the public sector, but we don't rely on ADP funding in the city in terms of our mainstream services. It's tended to be our ADP, which puts us in the position where it's tended to be our ADP funding is funding which can fund innovation, and we've used it in that way to test out new services, and we've used it to be a bit more innovative and a bit more kind of fleet of foot, if you like. So the nature of the ADP funding, whilst it's challenging about one-offs, is also the way in which we can test different approaches. So that might answer some of that.
Thanks, Suzanne. And Erica, you wanted to come in at this point?
Yeah, it was just a comment about the COVID outbreak that actually we continue to see our patients all the way through COVID with our nurses working in a just slightly different way, but we continue to face-to-face consultations because we do recognise the challenges that this patient group have, perhaps using virtual means. You know, they don't always have smartphones that they can connect to you with and all that sort of stuff. But I think COVID actually has brought some benefits, dare I say it, as an infectious diseases consultant that's really kind of struggled with this. But I think we should learn to look at what things have been able to be developed and the connections and the links that we have made through with different groups and how we've worked differently and try and capitalise on that. So I think there's been some positives, not many, but there's been some positives that have come out of this.
Thank you, Erica. So we're nearly at time, but I just wondered whether Fiona, if you wanted to come off mute and just leave us with some final reflections or a call to action, as it were, just as we end this session. I'm not seeing Fiona come off mute, so perhaps She's either away from her laptop or not. Oh, here we go. Fiona, over to you.
No, just what I'd said before.
Yeah.
We all need to work towards evidence-based drug policy reform. And the only way we're going to get there is to do it together. So I look forward with working with all of you, and see you on the 16th at our event with Peter, Helen Clark and Johan Harry.
Great, and we'll make sure we circulate that to participants as well, Fiona. So thanks everyone for joining us for this session, dealing with an outbreak as part of the Fast Tracking Scotland Summit. Our next session, we've got 2 more for today. Our next session at 4:30 is the power of peer support, and then at 5:30 we are discussing breaking down barriers for sex workers to get involved in policy work. So do join us when you can, and we'll see you all soon. Thank you very much.